Thank you for joining for the rest of the session for the annual Arab Pirates Association Congress. With this session, we'll do the abstract presentation. And in the abstract, we receive from individuals supplying us with their abstracts. So first of all, I'd like to thank the abstract committee for their effort in reviewing all these abstracts and also selecting the abstracts for oral presentation. We would like also to thank all the physicians and the people who actually submitted their abstract for our Congress. We wish that this goes on for the next Congresses as well. For not much delay in terms of presentation, I would like to present our first presenters. The committee has chosen 4 oral presentations to be delivered in this Congress, and we would like to start with the first one. So our first presenter is Dr. Induja Vishwanathan from India, from Mahatma Gandhi Medical College and Research Institute. She will present the abstract with the title, Altered Expression of Stress-Sensitive Signaling in PBMC of Hypothyroidism Subject Treated with Levothyroxine, a pilot study in the coastal region of Indian subcontinent.
Good evening, sir. I'm Induja. My topic is about the altered expression of stress-sensitive signaling in the PBMC of hypothyroid subject treated with continence. And the background of my study is it is a hypothyroidism endocrine disorder, and it is due to the insufficient of thyroid hormone productions, and it requires the treatment of levothyroxine. And oxidative stress causes the thyroid diseases, and it causes the low-grade inflammations in the metabolic disorders. And understanding the genetic expression of stress-sensitive signaling markers and inflammatory mediators could be personalized through the thyroid hormone replacement therapies. And moving to the aim of the study is to assess the genetic expression of stress-sensitive signaling genes among thyroid study subjects, and levothyroxine drug is compared with the control subjects. And the objective of the study is to assess the genetic expression of the stress-sensitive signaling genes in PBMC cells. And also we are assessing the demographic details of age, sex, and dose and duration of the levothyroxine for hypothyroid subjects. And also we are correlating the genetic expression of stress-sensitive markers and demographic details in the hypothyroid patients. Moving to the study subjects and method, it is a cross-sectional study. We are involving the hypothyroid cases and hypothyroid patients and healthy subjects who are visiting the Department of General Medicine and Endocrinology, MGMCRI. And we are obtained the informed consent from the patients, and we are recruited, and we are segregating it into 3 groups, that is healthy control. Next, group B is untreated hypothyroid, and group C is treated hypothyroid. And we are collecting the blood sample, and we are assessing the oxidative stress markers in that, and others remaining 2 ml of remaining EDTA sample is used for isolation of PBMC for analyzing the gene expression and the mRNAs. These are the gene expression markers, ERK, P38 MAPK, and GNP. And in demographic details, we are assessing the age, duration, and dose of the drug. And statistical analyzer, we are analyzing the ANOVA and crucial values test, and were done, and we are mean and standard deviation is calculated using the SPSS software, and P value is less than 0.5, so it is statistically significant. Then I'm moving to the result 1. In the result 1, we are assessing for the treatment who are taking with and without treatment patients to the we are comparing it to the control patients. In that, we are assessing the oxidative stress parameter, that is T-BAS and TAS. It is analyzed by calorimetric method and bioassays using. In the normal health, in this picture I am going to say, that is in this are the oxidative stress markers. In this pro-oxidant will produce a ROS and superoxidase, and over production will produce and counterbalance. And moving to the result one, in this we are assessing the T-bars T-bars in the serum sample. In this, I got the result of in group B and group C, there is an elevated level when compared to the group A. Continuation of the result one, in as I said in T-bars, I am saying in TAS also same. But in this, there is a increased level in the control, but there is a decreased level in the group B and group C. And we saw a correlation between these two parameters, these two markers. There is a negative correlation in this. And moving to the discussion, in this, due to the overproduction of the imbalance in the oxidative stress, there is an increase in T-bars and there is a decrease in TAS. And oxidative stress will produce and damage the cells, and it is oxidative stress will damage the cells, so it is producing MDA in that. Next, moving to the result 2, it is assessing the stress sensitive serine marker, that is ERK and P38, and the genetic marker genetic expression is JNK. It is assessed by method of RT-PCR. Moving to the MAPK signaling pathway, in that ROS is producing overproduction, so that oxidative stress will produce, it will activate the inflammatory markers and And then moving to the genetic expression result, in that there is an increase in the group B and group C. As in MAPK, there is an same increase. And in the gene expression, only in group C only it is increased, remaining two are decreased. In this, treatment improves markers. After that, moving to the last result, in this we are seeing dose and duration is increased only in the group C. There is a positive correlation in the gene expression only. These are the key findings.
Thank you so much. Moving on to the next presenter. Unfortunately, we didn't have time to go into questions and answer for the presenters, but we'll go directly to the second presentation. So the second oral abstract chosen is by Dr. Raja Matta from Egypt. She's a professor of endocrinology and diabetes at Faculty of Medicine in Minya University in Egypt. The title for abstract is Diagnostic Performance of microRNA 95 and microRNA 155 in thyroid cancer.
I present myself, Dr. Raja Matta, MD, Professor of Endocrinology and Diabetes, Internal Medicine Department, Faculty of Medicine, Minya University. I present my articles titled Diagnostic Performance of Micro 95 and Micro 155 in Thyroid Cancer Bethesda 4. The authors are precipitated in this study. Tissue microRNA 95 and 155 are generated by thyroid and excreted in the blood. This first study reported altered their tissue expression in papillary thyroid carcinoma. Fine needle aspiration cytology can help to diagnose up to 70 of cases. However, fine needle is not able to differentiate between follicular adenoma and follicular thyroid carcinoma, which may need unnecessary surgical manipulation as a diagnostic tool for Bethesda thyroid T4. Circulating biomarker for diagnosis of thyroid cancer is still needed, particularly in the follicular region. Our study are designed to measurement of micro 99 and the micro 155 for thyroid cancer and their correlation with clinical, cytological, and histopathological, as well as their clinical value in follicular lesion. The current study involves 4 groups: thyroid cancer group, benign nodular group, and non-nodal thyroid disease, and finally healthy subject. The 4 groups were age and sex matching. Diagnosis of benign and malignant nodule was based in post-operative histopathological diagnosis. Table 1 of our study that is allow us to know that microRNA 95 with significantly lower in thyroid cancer group compared to the other group, while the microRNA 155 were significantly higher in thyroid cancer group compared to other 3 studied groups. As this figure 1, it shows a relative expression of level of microRNA 95 among the studied group. Also, it is figure 2, it shows relative expression of microRNA 155 in the studied group. Figure 3, it shows a relative expression of microRNA 95 among patients according to the Bethesda cytological category. As we show in these figures, thyroid compared to healthy subject, microRNA 95 was significant lower in thyroid 4, 5, and 6 cases. Also, the second figure, it shows that the microRNA 155 was significantly higher in thyroid T and thyroid 4 and thyroid 5 and 6 versus healthy group. Also, this figure is a comparison of the level of microRNA 95 among the papillary carcinoma and follicular carcinoma and follicular adenoma. Expression of microRNA 155 was higher in the papillary thyroid carcinoma compared to follicular carcinoma and follicular adenoma. And the log curve analysis, it shows the diagnostic value of one of the microRNA 95 that is value less than or equal to 2.1 for thyroid cancer, with a sensitivity 96 and specificity of 88. Also, microRNA 150 with a level of more than 44 can discriminate thyroid cancer with high sensitivity and specificity. So this table, it shows that among the thyroid cancer group, the relation between these biomarkers with T staging and N staging, and it shows that among the patients with papillary thyroid carcinoma, microRNA 155 is related to the T staging and also in follicular thyroid cancer patient. Finally, we qualitatively evaluate the circulating microRNA 99, and that using the chosen cutoff value of microRNA for diagnosis of thyroid cancer, microRNA 95 and microRNA 150, they have high sensitivity and low specificity to diagnose follicular thyroid carcinoma. So this microRNA could be considered for prospective follicular thyroid carcinoma exclusion test. In summary, our data show the role of microRNA 95 and the tumor as a tumor suppressor gene, and the microRNA 155 as oncogenic seen among the healthy and disease to control the compared with. Also, further study are needed to measure microRNA and other panel for more diagnosis of thyroid cancer. The study of this target microRNA and their pathway will be significant as well. Thank you.
Thank you, Dr. Raja. We're moving on to our third oral abstract. This is from Vikeshwaran Vinayagan from Mahatma Gandhi Medical College and Research Institute in India. The title of the abstract is Reduce Circulating Levels of Transferrin Among Patients with Both Hyper and Hypothyroidism as a Possible Indicator of Long-Term Metabolic Complications.
Good afternoon. Thanks for giving me the opportunity to present my work. My abstract presentation entitled Reduced Circulatory Levels of Transferrin Among Patients with both Hyper and Hypothyroidism as a Possible Indicator of Long-Term Metabolic Complications. I myself, Dr. Vikeshwaran Vinayagam, Assistant Professor, Department of Biochemistry from India, MGMCRI, India. So, background information: thyroid plays a major role in cell growth and metabolism, and the synthesis of thyroid hormone requires iron, iodine, and other minerals. And recent research suggests that 30% of the study subjects who were on levothyroxine had chronic fatigue without anemia. So, iron deficiency is associated with the thyroid dysfunction and total body iron stores, and iron binding capacity may play a role in thyroid dysfunction. So in our study, what we have planned is our aim of the study is that to assess the anemia status in hypothyroidism versus hyperthyroidism disorders. So the objectives are to estimate the serum profile such as iron, ferritin, soluble transferrin, and thyroid profile in hypothyroidism and compared with the hyperthyroidism disorders. And objectives to assess the anemia status in terms of total body iron stores in hypothyroid versus hyperthyroid disorder and correlate with the severity of the disease. Coming to the study participants and the methods, it's a cross-sectional study, and the study participant includes both hyper and hypothyroid subjects, in addition to the control subjects who visited the Department of Medicine and Endocrinology, MGMCRA, India. So after obtaining informed consent, the study participants were divided into 3 groups: Group A, healthy control; Group B, hypothyroid; and Group C, hyperthyroid. Sample size were calculated from the reference article Ashuma et al. So the inclusion criteria for all these groups were as per the American Thyroid Association classification, and the exclusion criteria includes patients with anti-thyroid medication not less than 3 or more and hormone replacement therapy at the time of blood collection. So severely and acutely ill patients were not recruited, and cancer patients were removed, were not recruited in the study. So coming to the sample collection, the blood samples about 5 ml were collected, and the demographic details such as age, sex were included, and the blood parameters such as thyroid profile, T3, T4, TSH were measured to categorize the study groups. And from them, the serum ferritin, serum transferrin receptor level, hemoglobin, total body iron stores, transferrin, and clinical activity scores were measured. So coming to the result one, we assess the plasma levels of thyroid profile and the iron metabolic markers in hypothyroid and compared with the hyperthyroidism. So in this data, we found that this is the first one. Group A is control, Group B hypothyroid, and then C hyperthyroid. We found a generalized decrease in the transferrin receptor, serum transferrin level in both hypo as well as hyperthyroidism. But other parameters were not much significant in anemic profile, except the total body iron stores. The total body iron stores, we found a slight increase only in hyperthyroidism when compared to the control and hypothyroidism. So there is a significant difference between the hyperthyroidism versus hypothyroidism. Other parameters like total iron binding capacity and serum transferrin receptor, soluble transferrin receptor, and all were not statistically significant between the groups. So we found that in females there is the hemoglobin level were decreased when compared to the male as expected, and then we found that in general we found that there is a decrease in hemoglobin and serum ferritin that was found in females than males. Another finding is that the total body iron stores, serum transferrin level were lower in thyroid disorder than control. This low total body iron stores may be due to chronic anemia among thyroid disorder patients, and low transferrin in the long term may affect the kidney and heart, as evidenced in Aminat S. Agun et al. So that may be a predictor for future metabolic disorders. Thank you.
Thank you so much. Moving on to our last abstract presentation is by Dr. Ziad Badri from King Saud bin Abdulaziz University for Health Science in Saudi Arabia. The title of the abstract: The Impact of Subclinical Hypothyroidism on Lipid Profile in Jeddah.
My presentation is talking about my name is Ziad Abdulaziz Badri. I'm a 6th-year medical student from King Saud bin Abdulaziz University for Health Sciences. Our presentation today, or our research today, is about the impact of subclinical hypothyroidism on lipid profile in Jeddah. This research was done supervised by Dr. Mahmoud Zahrani and Dr. Fatma Bagar, and it was done in a single center study, which is King Abdulaziz Medical City in Jeddah. Moving on to our content of this presentation, which is under introduction to subclinical hypothyroidism. It is a brief introduction about it, methods and results and discussion and conclusion and limitation. To begin with, subclinical hypothyroidism, as we know, it's a high TSH levels and a normal serum free thyroxine concentrations. As we know also, prevalence of subclinical hypothyroidism is becoming more in our population. It can reach actually to 4 to 8% in the general population. It can reach to 15 to 18% in women age over 60. And also, it's becoming more prevalent in our community. About the impact of lipid profile, what we already know in the literature, that lipid metabolism is regulated in large part by thyroid hormones. It could be connected to change in a lipid profile. As we know also that both primary or secondary hypothyroidism actually are associated with hyperlipidemia, and most of our literatures are saying that. However, there are no actual information about the subclinical hypothyroidism, and does that affect the lipid profile as the thyroid hormone is affecting it, or the hypothyroidism itself, because as you know, there is a difference between the two diseases. So this research was aiming to evaluate the relationship between the subclinical hypothyroidism and the termination in the lipid profile or changes in the lipid profile. About the methodology of this study, it is a retrospective cohort study. It is done in 208 patients. It was divided into two groups. 99 were affected group and 109 were controlled group. Actually, it was done from 2015 to 2022. It is actually randomized between these years, and inclusion criteria, all the patients of subclinical hypothyroidism were included, and exclusion criteria, we exclude all patients that it might affect the lipid profile, such as previous dyslipidemia and pregnancy, cancer, liver diseases, end-stage renal disease, and diabetes. We actually, in the statistical analysis, we used R software version 4.2. Continuous variable were represented by mean and standard deviation, and categorical variable by frequencies and percentages. We'll kick some rank, some tests also, compared clinical characteristic of lipid profile before and after the treatment, and also it was used for comparing clinical characteristic and lipid profile between subclinical hypothyroidism patient and control group. Moving on to our results, we actually have significant results. These are the demographic data of our population. Predominantly, they were male. 45 years is the median of age. The most common comorbidities was hypertension. These are some definitions of the study that might help you that how we diagnose subclinical hypothyroidism. There were a diagnosis of subclinical hypothyroidism in the database of the patients. So that's how we took the patient of subclinical hypothyroidism. Here are the significant results. We actually found LDL before treatment is ranging in the pathological area of the affected group, as you can see here, 4 is the LDL before the treatment, and also the range is from 3.07 to 4.86, which is very high compared to an LDL before treatment of control group 2.89. So that would actually raise our mind to that the LDL is pathological. The HDL also, there is a difference between them. However, it's not that big difference. Actually, also the total cholesterol showed the difference. However, there were not a significant p-value. In the triglyceride before the treatment, also we found a significant result that that ensure that affected group are worsened in the triglyceride more than the control group. You can see also in the diagram here, you can see that participants with dyslipidemia that were not diagnosed with dyslipidemia, they were not actually diagnosed in the database of their files to be diagnosed with dyslipidemia. However, after we checked the time that subclinical hypothyroidism exists there, they were actually diagnosed with dyslipidemia, and as you can see, the affected group are more in every diagram. Moving on, this is a secondary finding for vitamin D deficiency or for vitamin D25 and the hemoglobin A1C. We actually found significant data about them. We actually found the vitamin D is ranging in the pathological area of the affected group, as you can see here, 44, which means the vitamin deficiency, from 30 to 70, actually the range of the affected group, and the controlled group were 60 and ranging from 40 to 86. That's a huge difference between the two numbers. The hemoglobin A1C we found actually to be higher in affected group, but is not that much. However, we found it to be more significant in the hemoglobin A1C. Moving on to our discussion, we think that the decrease in the activity of lipoprotein lipase in adipose tissue and hepatic lipase is hypothesized to be the cause of elevated triglyceride level in subclinical hypothyroidism. According to some literatures, they are saying that. So also the high level of LDL may be attributed to decreased transcription of LDL receptor gene. It might be related to a genetic area of experience. Also, dyslipidemia plays a role in decreasing increased cardiovascular disease in patients with subclinical hypothyroidism. We actually in the treatment of subclinical hypothyroidism, we actually do not treat subclinical hypothyroidism. Or we observe the patient, or we give them levothyroxine. So there are no specific guidelines that saying it must be subclinical hypothyroidism must be treated with levothyroxine. However, levothyroxine actually improved the LDL and cholesterol level, emphasizing the role of thyroid. So it must be actually added to the guideline that levothyroxine must be added to patients with subclinical hypothyroidism to prevent actually further complication of the lipid profile. Moving on with the secondary findings, we actually found that vitamin D deficiency actually delays the progression of autoimmune hypothyroidism, further emphasizing its role in the pathogenesis. The findings are not confirmed to autoimmune hypothyroidism, as the association was shown between subclinical hypothyroidism and vitamin D in children age. This is in pediatric age group, so we can actually depend on this study. However, further study as a multi-center study actually need to be proving the association between vitamin D and subclinical hypothyroidism. In hemoglobin A1C, It's hypothesized that hypothyroidism causes insulin resistance and plays a role in development of diabetes mellitus. This is in hypothyroidism. A recent study found a significant positive association between TSH and hemostatic model assessment of insulin resistance. However, a recent systematic review found no association between the two areas. So it might be actually a result of coincidence. It's not. It might be not that much to be approved, because as I showed the result, there were no actually a big difference between the two numbers. I think it was very mild difference between them, between the controlled and the affected group. This is our conclusion. We think that vitamin D and LDL range in the pathological area of the patient of the normal ranges, so it must be treated and by levothyroxine. And also we might actually consider observation, but not that long, because we need actually to secure our patients from not developing dyslipidemia. That was my research for the conclusion. For the limitation, as I said, retrospective study and a single center study, so it need multi-center study. Some incomplete data was actually a challenge for this research. This is my reference, and thank you.
Presenters today, also extending thankful for all the authors who submitted their abstract to the Congress. This concludes the abstract session for this day. We will announce 2 winners out of the 4 people who submitted and did their oral abstract today as a first and second winner. Please stay tuned for the rest of the program. We'll announce the winners. That concludes this session. Then we move on to the next session, will be the Amgen Symposium.